As always, our mission statement is that Scrubs is a student-driven initiative that aims to develop supplemental resources for current and future cohorts that will pass through Brody. We participate on a variety of subcommittees working to create resources for students by students with the aim to offer a unique perspective of students who have walked through the same shoes, developing resources we wish we had been exposed to during our time in the course. The hope is that this will become a staple of the student body, and in order to do so, we always need new members from new classes, so if this is something that aligns with your interest, we would love for you to join the team in the future. And as always, brief disclaimer, these resources are made by students, not by faculty, so there is a possibility for errors, though that is attempted to be mitigated as much as possible through multiple stages of vetting. If there's ever contradiction with your coursework, please go with materials that are provided by your course. As well, these are supplemental resources that do not include a holistic view of your course, so make sure you're referring to your course materials and using that as the final say in any studying that you are doing. With that, let's get into some material. So we're going to start with just some brief descriptions that your course pack gives of the normal anatomical description of the vessels that pass through the pelvis. Now I'm going to go ahead and say that there is a good amount of anatomical variation that happens in real life when you're talking about these vessels. So imaging is always a good thing to do for any kind of operation happening in this region. But we're going to talk about kind of the normal branches and the way that you're going to be tested on computer exams. The lab exam will they'll often tag something that is has a more normal variation, doesn't have anything weird going on. So with that, we'll talk about the obturator branch. Everything here is off of the anterior division of the internal iliac, which we'll see in the image shortly. But off the anterior division of the internal iliac, we have the obturator branch, which is the first branch of the anterior division, and it passes through the obturator foramen with the obturator nerve to supply the medial aspect of the leg. And actually that should say medial aspect of the thigh, specifically because the leg refers to the knee down, so just make a mental note that should say thigh. The internal pudendal artery. The internal pudendal artery passes through the greater side of foramen with the inferior gluteal artery, and this is prior to passing through the lesser side of foramen into the perineum. Remember, the internal pudendal artery is going to pass with the pudendal nerve, and it's going to make that very interesting pathway that is very important to know, going through the greater side of foramen and then back into the perineum through the lesser side of foramen. The inferior gluteal artery that passes the greater side of foramen below the piriformis muscle and supplies the region of the gluteus maximus, running with the inferior gluteal nerve. The umbilical artery. Umbilical artery is a branch of the anterior division that gives off the superior vesicular branch. The umbilical artery is in adults and often in children. It has been obliterated because this is a vessel that we no longer need because we're no longer attached to the placenta that was providing us with blood from mom. The inferior vesicular artery is another branch of the anterior division. Sometimes this can be a little bit variable, but we're going to say that in general it will usually arise with the medial rectal artery. And then the uterine and vaginal artery, again, somewhat variable, but let's talk about these as coming off branches of the anterior division where they're going to supply the indicated structures. So the uterine supplies the uterus, the vaginal supplies the vagina. And those can often come off in pairings with the inferior vesicular, medial rectal, things like that. But for now, we're just going to kind of take this as the basic overview. And lastly, we're talking about the internal iliac. It has an anterior and posterior division. So the posterior division of the internal iliac has three vessels that we need to know. There is the iliolumbar. This is the first branch of the posterior division, and it's going to pass up superiorly, and it's going to end up bifurcating into an iliac and lumbar branch. So that's where it gets its name, iliolumbar, and those are going to supply the regions that they indicate. Iliac branch is going to supply the ilium, and then the lumbar branch is going to supply the iliopsoas and things in that region. The lateral sacral artery or arteries, there can be one or two here. If there's two, they are referred to as superior and inferior lateral sacral arteries. They're going to come off the posterior division and supply the lateral sacral region. And lastly, the superior gluteal artery is the continuation that goes out of the pelvis via the greater side of foramen above the piriformis muscle, and it's going to be supplying the region of the buttocks. All right, and with that, let's actually look at how this looks in the body. So this looks like a lot's going on. We're going to try to break this down as much as possible. You don't need to know everything here. Also, because cadavers are going to be male or female, just like people are, you are going to see that some of these things are not going to correspond to a male or a female. So I've marked things. Interestingly, this image tries to join the two together. So you have a uterine artery and an artery to the ductus deferens in the same image, which is not something that you would actually be able to see in real life. So let's start with talking about our aorta. Our abdominal aorta comes down, it's going to bifurcate into common iliac branches, and then as we go from our common iliacs, we're then going to get an external iliac branch and an internal iliac branch. So this internal iliac artery is sometimes referred to as the hypogastric artery by clinicians, and that's helpful because we're going to talk about some nervous structures in a moment that are going to refer to superior and inferior hypogastric plexuses, and it's important to recognize that that's referring into relation of the internal iliac artery. So the internal iliac artery continues down inferiorly, and this is where we're going to get some branches. So there's two main branches. There's the posterior division running posteriorly and the anterior division running through here. So what I want to point out is from your course pack, we're going to consider this first branch here, the obturator artery, as being the first branch of the anterior division of the internal iliac artery. So here goes the obturator, it's coming anteriorly, and then it's going through the obturator foramen. Okay. Now another branch that your course pack doesn't consider the first branch, but a branch of the anterior division, is this umbilical artery. And the umbilical artery is often the artery that later gives off the branch that is the superior vesicular artery. And that's actually labeled here in this image. This branch here is a vessel that's only given off in males. This is going to be the artery to the ductus deferens, and that often comes off the umbilical artery as well. If we continue distally along the anterior division, we are going to see the inferior vesicular artery, which we're going to group this together with the medial rectal, which is indicated here. These can kind of come off in variable places, but sometimes they come off together. And then here we have the uterine artery. And really all three of these vessels can come off in the same region. We would also have one vessel that's not shown, which is the vaginal artery. So those four are located kind of the same region, and they have either they come off together, they come off individually, they come off in pairs. It kind of depends on the person for that. Okay, and then what I want to point out is there's two terminal components of the anterior division. There is one here that runs posteriorly through the greater sciatic foramen underneath the piriformis muscle, which is what we're seeing here. So there's the piriformis muscle, here's the greater sciatic foramen as a whole, and here's this vessel running through the greater sciatic foramen and running posteriorly. This is going to be your inferior gluteal artery. If you see this other vessel that also goes through the greater sciatic foramen, but then it wraps around the sacrospinous ligament and into the lesser sciatic foramen right here, that is going to be your internal pudendal artery. And we know from previous videos, your internal pudendal artery is going to run inferiorly, and it's going to give off an inferior rectal branch before it goes to the rest of the perineum. So that takes us through our anterior division. Our posterior division is, again, really going to have three vessels we need to know. There's this first one that runs up superiorly. So it comes off, runs superiorly. This is our iliolumbar. So eventually it would come up and it would branch into an iliac branch and a lumbar branch. So iliolumbar, then our next branch is going to be lateral sacral. So again, lateral sacral, there could be one, there could be two. I most often see this as two vessels in the cadavers. And then this continuation that runs posteriorly. So it's going through the greater sciatic foramen above the region of the piriformis. So there's the border of the piriformis. And you see it's going above that, going out to the greater sciatic foramen. That's going to be your superior gluteal artery. And then later on in the course, you'll learn the branches of the external iliac. So that's something like your inferior epigastric artery, this branch of the pubic branch. You're going to have a deep circumflex iliac. Those are things that you'll hit on a little bit later. And then eventually when it comes out of this, below this inguinal ligament, that external iliac artery is now referred to as the femoral artery. So while I think it's helpful to look through this in an image that puts us in a 3D relationship, that's how you're going to see in the body. When I'm studying for computer exams, and even when I'm just studying on my own, I like to just break this down very simply into straight lines and where are my branches. So I'm going to show you how I study that on this next slide. Okay. Here is a much simplified version of what we were just talking about. This really just takes you through each of the branch points and names kind of the vessels that you would expect to see. So this would be our common iliac coming down. I know off of my common iliac, I have two main branches. I have the external iliac and I have the internal iliac. From there, I'm just following the internal iliac and looking at its branch points. So internal iliac comes off, and then the two major branches are the anterior division and the posterior division. From there, I just follow what vessels come off of each division. So starting with the posterior division, as I work my way distally, I'm going to have the iliolumbar come off first, lateral sacral come off next, and then again we can have one or two branches, and then finally we're going to have a superior gluteal. And what I've done here is you see this kind of shaded area. This is representing the greater sciatic foramen, and then this orange circle is indicating the piriformis. So it's just let me know that superior gluteal artery is coming off above the piriformis muscle. Then as I follow the anterior division, I can now go back and see the exact same vessels again. So the obturator, this little shaded area, tells me it goes to the obturator foramen. I continue distally, umbilical, and superior vesicular. Keep on going, inferior vesicular with medial rectal. And then I have the uterine and vaginal down here because they're not always shown, depending on if you're a male or female. And then if I come distally, the two terminal branches that I need to know are the internal pudendal and inferior gluteal. Both are passing on the inferior through the greater side foramen, so in this blue area, inferior to the piriformis muscle. So I draw this once or twice, maybe 3 or 4 times if I need to, just really briefly. And this is a drawing that I can do easily on an exam because it's just a bunch of straight lines. And this kind of helps me keep in mind where branch points are. Doesn't help as much on the practical exams because I need to be able to identify by sight. But this is just a general idea to keep things in mind that kind of reduces the information that you need to know to the bare bones. Now, something that is always important and always gets asked a question on is lymphatic drainage from these regions. So there's really 3 big points that you need to know. They're up here in bold. So first, the superficial inguinal nodes are going to be draining the perineum, everything besides the glans, penis, and glans clitoris, along with the inferior 2/3 of the vaginal canal and the inferior anal canal. And specifically with the inferior anal canal, we're talking about the region inferior to the pectinate line. So here's a pectinate line here, indicated in this image. The region below that is drained by the superficial inguinal nodes. The internal iliac nodes are going to be draining the upper third of the vagina and the pelvic viscera, and the periaortic nodes are draining the testes and ovaries. And you can kind of see that over here on the right. This is an image from Emboss that I like a lot. Unfortunately, it doesn't really show you the nodes very well, but it kind of has the reason that it's important to know lymphatic drainage. So for instance, the internal iliac nodes, which we talked about draining the upper third of the vagina and the pelvic viscera. Pelvic viscera include the bladder and the uterus. They can give you an indication if they're swollen that there might be a cervical cancer, bladder cancer, prostate cancer, or some kind of STI that's ascended into the uterus. And then same thing with testicular cancer is a common thing in young boys. And if the periaortic nodes are swollen, it can tell you that there might be a testicular cancer that you need to be aware of. So that's why the lymphatic drainage is important clinically. It's also very important because you're almost guaranteed to get a question on the exam. Now, this is a throwback to the abdominal plexus. So this is really, we're just going to focus on the inferior regions and how the inferior plexes innervate the pelvic viscera. So we're talking about the inferior mesenteric, superior hypogastric nerves, and inferior hypogastric plexus. And really, I just want to remind you of the components that are made up of each one of these plexuses. So the inferior mesenteric plexus is a continuation of fibers from the intermesenteric plexus, really meaning that it has sympathetic components from L1 and L2. The parasympathetic components, however, for everything from the inferior mesenteric plexus down, is going to be from the pelvic splanchnic nerves, which are going to be S2 through 4. So these are parasympathetic components. So all the parasympathetic components to the pelvic viscera are S2 through 4. And then the sympathetic components are going to be by the either the continuations from the inferior mesenteric plexus, which are L1 and 2 from the upper 2 lumbar splanchnic nerves, or from the lower 2 lumbar splanchnic nerves, which still have the same spinal components L1 and L2. So sympathetics follow along L1 and L2, while parasympathetics follow around S2 through 4. This will be important because we'll talk about how sensation to pelvic viscera is running along parasympathetic or sympathetic pathways based on where the damage is. And with that, you can kind of guess where the referred pain is going to be. If it runs along parasympathetic regions, it's going to be referred to the S2 through 4 region. If it's running along the sympathetics, it's going to be running along the L1 through L2 region. So this is just a good review table from something that came up previously in the course. Okay, now talking a little bit about functional anatomy. In the sexual response cycle, there's really 4 phases that we break this down into, just kind of for our understanding. A lot of studies have gone into this and kind of show that this isn't really true for everybody. This especially isn't true for male versus females, but we're going to talk about it this way in terms of just understanding the anatomy. So first we have an excitement phase, followed by a plateau, followed by orgasm, and then we have resolution. So let's start with what happens in each one of these phases. Everything that happens in the male is indicated in blue. Everything that happens in the female is indicated by pink. And if it's something that's important for both, is indicated in black. So in the excitement phase, we'll go through just the male first all the way through. For males, this excitement phase is characterized by erection, stimuli that is activating the parasympathetic nerves, important to note this is parasympathetic controlled, leading to vasodilation and engorgement of the penis. And then you have contractions of the ischiocavernosus and bulbospongiosus to assist in maintaining that engorgement. In the plateau phase, you just have further engorgement, and then eventually get to orgasm, which in males is synonymous with ejaculation, which includes peristaltic-like contractions of the ductus deferens, seminal glands, prostate, and it is going to expel sperm, leading to emission. And you have the internal urethral sphincter contracting, which inhibits retrograde ejaculation. This will be a point that we'll come back to in just a moment. And then lastly, the resolution is via the refractory period. Difference between excitement and orgasm is the sympathetic versus parasympathetic control. Excitement is via parasympathetics, orgasm is via sympathetics. And that'll be true for both men and women. Okay, so the female sexual response cycle, excitement is going to be characterized by vaginal wetness and clitoral enlargement, which is under parasympathetic control. This vaginal wetness is often due to vasocongestion under parasympathetic control, which is continued in the plateau phase. During orgasm, there are rhythmic contractions of the vagina and the uterine fundus, and you may have fluid expulsion that is often from the periurethral glands. And then in resolution, you go back to normal pre-excitement levels. We know that in females, oftentimes you can still go, instead of coming all the way down to pre-excitement levels, you can often dip down into the plateau or excitement phase. And then have continued orgasms, whereas males have a refractory period where no matter how much stimulation they receive, they will not be able to maintain their erection. Okay, we're going to finish up this video with some clinical anatomy. The first clinical correlate that we want to point out is the ureter injury during hysterectomy. So because the ureter is bringing urine from the kidneys down into the bladder, the ureter passes just underneath the uterine artery in the female. So during a hysterectomy, which is a procedure to remove the uterus, the uterine artery has to be severed to stop bleeding. And if you are not careful, then you can actually sever the ureter as it passes underneath the uterine artery. So this is the water under the bridge analogy. In females, the ureter passes underneath the uterine artery. So that's water under the bridge. And in males, there's also a similar thing where the ureter passes underneath the ductus deferens. So in both males and females, there is a structure that's over top of the ureter, and this is a really high yield point. So if you get a question about someone's going to surgery, they had a hysterectomy, and now they've got fluid in their pelvis, think damage to the ureter, or this could come up on the practical exam where they show this relationship, and you have to know what goes above and what goes below. Now, because we talked about the innervation to the pelvis is again by those parasympathetic and sympathetic nerves. If it's the sympathetics, then it's going to be from the lumbar splanchnic nerves L1 and L2, and then if it's parasympathetic, it's going to be from the pelvic splanchnic nerves S2 through 4. The parasympathetic nerves are they're responsible for contracting the detrusor muscle, which is the muscle of the bladder, and that's muscarinic controlled. So we can use this to our advantage in medical management. If we're trying to decrease someone's urine, we can block those receptors. But if there is a surgery in which the parasympathetic supply to the bladder gets damaged, then we can no longer contract the detrusor muscle the same way that we should. And that can lead to overflow incontinence, which isn't really shown in this image, but it would be where we can't contract. So now we get fluid building up, and the bladder will distend, and there's not really anything that we can do to get it out. So that would be an example of overflow incontinence. And that is due to parasympathetic damage, because parasympathetic components is what are the fibers that are going to cause contraction of the bladder. Kind of on a similar but slightly separate note, we have what is called retrograde ejaculation in males, and this is due to hypogastric plexus injury that damages sympathetic components. So the sympathetic fibers during orgasm are going to cause contraction of the internal urethral sphincter. So the internal urethral sphincter is a functional sphincter at the base of the bladder. In males, when there is an ejaculation, the ejaculate should come out like this. It goes into the prostate, and then it should be expelled along the penis and out through the external urethral orifice. But if there is loss of sympathetics that are contracting the sphincter up here, then that can allow for fluid to go backwards. And often this will present as someone coming in saying that they can still have the sensation of orgasm and they can still feel themselves orgasming. However, they are not able to ejaculate and have emission of fluids. And this is because their ejaculate is actually going up into their bladder, so they may say that they have to pee right after sex. Lastly, we're going to end this on referred pain from the pelvis. Referred pain from the pelvis follows the general guideline that the pelvis is supplied, or that sensory information is going to flow backwards through parasympathetic pathways, which again we mentioned were pelvic splanchnic nerves, S2 through S4. So that means that referred pain from the pelvis typically is going to go along the S2 through S4 dermatomes. However, there is an exception to this rule. Up here, the uterine fundus, which is at the top of the uterus, is supplied by sympathetic innervation. So the sensory information goes back along the sympathetic pathway, which is L1 through L2. So you're going to have referred pain into the L1 and L2 region, which is going to refer to the low back area. Okay, so big takeaway here is using the S2 through 4 versus L1 through L2 regions to differentiate regions of referred pain if you get a question about low back pain versus suprapubic pain. And with that, that should bring us to an end of this video.